Hello, I'm here with my surgeon, Dr. Jorge Acosta. He's a member here at the Bariatric Center at Las Palmas del Sol, and I can highly recommend this man. He's one hell of a good surgeon. I came through the surgery without any complications, and thus far I have lost 64 pounds, and this is in 3.5 months. Why don't you go ahead and tell us a little bit about the different procedures that you perform? Maybe give us some information as to how long you've been actually doing this. And I know you like it because you're so good at it. You don't get good at something unless you like it. So I know you love what you do.
Yeah. So we here at Del Sol Bariatric Center, we perform two of the main procedures that we perform are the gastric bypass and the vertical sleeve gastrectomy. All procedures that we perform are done with a laparoscope. They're done minimally invasive. Set of small little tiny incisions, about the width of my index finger, done through a laparoscope via a TV monitor. And the big advantage of doing them that way are that people recover very, very quickly. Like our good patient here can attest to that. Recovery is very quick. Pain usually not much of an issue after surgery, so recovery is really good. Depending on the patient, depending on what comorbid conditions the patient may have, we'll try to advise for gastric bypass or sleeve. They work a little bit differently. Both of those do, however, do a great job at helping patients with their weight loss. And not only do we do it for patients to lose weight, but we also do this to make their lives better, make it so they can move around and do the things they like to do.
Yeah, more energy.
More energy.
Much more energy.
A lot of our patients have significant comorbid issues. A lot of them have diabetes, they have hypertension, they have bad heartburn, they have bad joints, they have backache, knee pain, sleep apnea. So, a lot of things that we find out is with weight loss and with some of these surgeries, it does help a lot for those problems to go away or get better. And sometimes even without having all those bad medical issues, just the fact that people lose weight protects them against developing those bad comorbid conditions or those bad medical problems that can come about later on because of the weight. So definitely, very useful. Takes, obviously, a good surgery is very important, and that's what we're here to help with. Good patient, such as you, incredibly important because it's not only the surgery, but it's actually the patient listening to what we instruct. We have a full team approach: the dietitian, the nurse. It's not only the operation, but how you're eating, what you're supplementing, you're exercising. Mm-hmm. So obviously, having a very good, compliant patient that follows the instructions and does the right things makes the perfect recipe for things to go in tune and have great success stories such as yours.
Not only that, but the fact that your taste buds, your desires for sugar cravings, at least from my perspective, completely go away after the surgery. I have no sweet tooth any longer, and I had a major sweet tooth, so this is a major achievement for me, like I said, to drive by a Krispy Kreme donut and have it be as enticing as a title loan for car company. It's meaningless. And same thing in the groceries. I walk by, the ding dongs, the cupcakes, and it doesn't mean anything. Yeah, it may as well be a pair of shoes. It doesn't mean anything. So that's a fantastic attribute to this surgery, at least from my perspective. Is it common for people to lose their desires for sweets after this surgery?
Very common. It's for whatever reason, probably not well elucidated, but taste buds kind of change. Your preferences before you wear a sweet tooth. It's not uncommon for a big majority of patients to no longer have that sweet craving, which is yet another thing why the surgery is very helpful with weight loss, because your cravings do change.
Mm-hmm, absolutely. And I noticed that in the seminar you were discussing the basic surgeries, the lap band, the gastric bypass, the Roux-en-Y. You didn't really go into the duodenal switch. Do you feel that there's a particular surgery that's better for specific patients? I know that some patients that are 500 pounds, they might require a sleeve first, and then you go in and after they've lost some weight, you'll redo it to a Roux-en-Y gastric bypass. but you perform very few lap band surgeries. And is there a specific reason for that?
Yeah, I think me, along with probably the majority of the country, at least surgeons in this country, have found that long-term lap band patients may, for a majority of them, are not quite as successful as what we see with sleeve and gastric bypass patients. Sleeve and gastric bypass patients tend to do a lot better. And the other thing why a lot of surgeons in the country are shying away from lap bands is that long-term, we're talking 5, 6, 8, 10 years later, with lap band, we tend to see long-term problems, slippages, erosions, chronic heartburn, dysphagia, et cetera, and the extraction rate for those patients that have lap bands tends to be high. Probably about 35% of patients that have a lap band long-term, eventually, band will have to come out for a number of reasons. So that's why a big majority of surgeons in this country, not too crazy to push a lap band very often. The other surgeries, duodenal switch is another procedure that's done not very often in the U.S., and that's because duodenal switch has a lot of malabsorption. It's mostly malabsorptive surgery, so that requires a very intensive team to be on top of patients to make sure that they don't have protein malnutrition, and so on and so forth. So for us, that's a little too extreme of malabsorption that we would feel comfortable with, so we don't offer that very widely. The happy medium of malabsorption is the gastric bypass, the Roux-en-Y gastric bypass. Good malabsorption, good restriction, and good results. In regards to treating medical problems, generally, we tell patients that for the treatment of diabetes, bypass number one is the one that will do it better, particularly ones that are already shooting insulin, high dosages of insulin, probably going to be more likely to sway more towards a bypass. Okay?
So the people that are pre-diabetic, they would be better suited with the vertical sleeve gastrectomy.
Pre-diabetic patients do great with bypass and sleeve. Both of them will take care of it. Diabetic patients who are taking pills only, generally they'll do great with both surgeries. But if you're shooting 100 or 150 units of insulin every day, you're probably best suited with a bypass. It's going to take care of that better.
And so how many years now have you been practicing bariatric surgery?
I've been out in private practice going on 11 years.
So you've done thousands of these then?
We're total since training about 3,500 procedures. Here in El Paso, it's over 3,000.
And the majority of those procedures, what would you say, were they gastric sleeve or bypass or what?
Majority of them are gastric bypass, and that's because bypass has been approved since then. Sleeve recently became approved by insurance companies maybe about 3 or 4 years ago.
Yeah, that's a very good point, because my insurance company was fantastic. They covered virtually the entire bill. I wound up having to pay maybe $2,000 out of pocket. So
yeah, and that varies. Okay, some have horrendous deductibles and horrendous copays, and some cover everything. So that's something we need to check with your insurance carrier, because it varies from person to person.
So I noticed that when I discussed the procedure prior to the surgery, you were telling me how you actually go in and you oversew the entire staple line after removing the stomach, and you also remove all the portion of stomach, the diaphragm at the fundus. And that's really important because that's the only area of the stomach that basically will stretch after surgery, right?
Absolutely. So the fundus comes out, and that's what expands the most on their normal stomach, and that's what allows you to have a lot of capacity when you eat. So by removing that during a sleeve, gives you a very nice restrictive stomach pouch that doesn't really have room to stretch or expand that much. In addition to that, the portion of stomach that comes out makes a hunger hormone, referred to as ghrelin. So when that comes out, when we remove that portion of stomach, hunger drive also goes away, and that's what you mentioned to me, that you experience that you're not really hungry. You eat because it's time to eat, not because of hunger. And that's part of it. Part of the reason why that happens.
That's a fantastic feature to this surgery, because I do not get hungry. It's just incredible. I mean, and that certainly gives me long-term results that I want to achieve to lose weight. I know that it's not coming back. I know every pound I lose is going to be gone forever. I can't see it ever coming back. Unless I was to take an apple pie, throw it in a blender with a half-gallon of ice cream and drink that.
That's horrible. Don't do that.
You have to still eat right. You have to still do the right things, but with the excess energy you have after the surgery, it really makes a strong impact. And you with the weight coming off rapidly, you actually get the desire to actually work out and live a healthy lifestyle as opposed to the old lifestyle that you had. And if you're watching this video, you're watching it because you're overweight and you're looking for a solution. This solution, I'm not going to say is for everybody, and it's certainly not the quick and easy route to weight loss success. I mean, it took a great deal of consideration, time, and money, and most of all, I had a needle phobia, and I overcame it, and I went ahead and did it, and I have no regrets whatsoever. I would do it again tomorrow. But number one, you got to find a great surgeon. Dr. Jorge Acosta, fantastic surgeon. Highly recommend him. Again, we're here in El Paso, Texas, at the Del Sol Medical Center. And if you have any questions, you can call this center and set up an appointment for a seminar that is held. Is it still held weekly?
Yeah, we have 4 seminars every month. Free informational seminars. You just want to come in and listen and see what it's all about. Set in for free and purely for information, so that people know what this is, how it works, what the numbers are, et cetera, et cetera. So I think that's always a great place to start, is with information. And like Rick said here, it's not the easy way out. Far from the easy way out. Actually, there's a lot of work. He's done a lot of work and he's having great results. But takes 2 to tango. We have to do a good operation, and we have to have a great patient that does the right things to have excellent results, and that's how it works.
Doctor, a lot of people might be wondering how much stretch can they expect from a sleeve gastrectomy surgery?
Yeah, so most of these surgeries bypass sleeves and bands. Over time, the pouch does tend to expand inevitably. The first 3 to 6 months, that's when people are probably most restricted, and after that, they may lose a little bit of their restriction. But what we tell you as patients is, as long as you're respecting that pouch, if you're eating to the point that you're comfortable, you're not eating to the point that you're about to vomit. If you eat to that point every meal, then that's going to want to get bigger. Mm-hmm. A big culprit too is going to be sodas, carbonated drinks.
Oh yeah,
carbonated drinks. They hit that pouch, bubbles expand. You do drink that every day for a couple of years, it's going to get bigger. So as long as you respect that pouch, you do the right things, you don't do anything to harm it, it's going to remain small for many, many years to come.
I actually thought that I was going to miss sodas or fast foods. I was a fast food junkie, and I haven't had fast food in 3.5 months, and I have no desire for fast food. I have no desire for soda. It's just wonderful. I can't tell you people how wonderful it is. I mean, you'd have to experience it for yourself in order to find out for yourself. But it's your choice. Make a lifestyle change. You only live once, and you don't want to spend the rest of your life overweight. Yeah. And of course, that also causes people to die off prematurely. I know that they're more susceptible, like as you said, to heart attacks and diabetes complications. You could lose a limb, arm, leg from diabetes. Who wants that? Then you're going to wind up having surgery anyway. You have your leg amputated, get your stomach taken out. No,
obviously, just like he did, get informed. That's, you're looking at videos like this is because you want to get information. Definitely get informed. Get to the seminar, learn, read about it, and before you make that big decision.
And on the stomach, when you remove the stomach for the vertical sleeve gastrectomy, approximately how much of that is actually left in the body?
Yeah, you probably end up removing close to about 3/4 of the stomach. So you're left with about 1/4.
About approximately 25%. But then when you oversew it, I know
it gets a little smaller too.
So you use a French bougie, and when you oversew it, what did you use on? Do you remember on me?
For a sleeve gastrectomy, my routine is 36 French bougie.
So by the time you're done oversewing it, it's approximately 32?
That's probably close to 34, somewhere on there.
Okay, 34. Yeah. So even if it was to double in size, which is unlikely, right? That it would, right. Even like 10 years from now, it shouldn't be twice as big.
Right.
So basically, the content of your stomach was basically going to be the size of a banana after surgery. Maybe 2 bananas like 10 years from now? I don't even think that.
I remember the portion of the stomach that stretches that allows you to have capacity to eat.
The fundus.
It's not there.
Yeah.
So if it does stretch, it won't stretch to something significant. But
Also, I was really concerned, because the stomach pouch it holds about 4 ounces after surgery.
yeah, it's roughly capacity-wise, it's probably about between 80 to 100 cc's.
What I do is I actually have a measuring cup. It's a half a cup, and I scrape it flush with the top, because if it's slightly rounded, that's too much. I know that. And I thought that I was going to have complications with water consumption, because you're supposed to have about 72, 74, 75 ounces of water each and every day. And I thought, how am I going to get that amount of water in a sleeve that's only 4 ounces? I thought I'd be, drinking water constantly all day long, which really, it turns out that that's not really the case. I know that the sphincter valve, the pylorus, actually opens up quite a bit faster to remove water from your stomach as opposed to food. Now, when you eat food, you're supposed to wait 30 minutes minimum before you consume any water. 30 minutes before you actually eat, you're supposed to stop drinking water. So food takes a little bit longer to get past that pylorus valve, so that's why you want to avoid drinking anything for 30 minutes after a meal and 30 minutes before a meal. But other than that, I drink water, quite a bit, and I have no problems consuming the 74, 75 ounces of water per day that's required. So, Doctor, thank you very, very much.
Thank you. Keep it up. Keep up the good work.
You're a gentleman and a scholar and a fantastic surgeon, and I recommend you to, I've actually recommended you to people on the street that I see are overweight. And, it's difficult to start up a conversation. Hey, buddy, man, but if they're susceptible to being spoken to, I can usually tell, and I tell them, how it is.
Good for you.
But anyway, you're saving lives.
Well, thank you. Thank you for arranging this video. And if we want to do any more video interviews, I'm more than happy to.
Okay.
Okay.
I'll take you up on that. Thank you
good
very
care.
much.
All right.